Good afternoon, everyone, and thank you for joining us for our sixth workshop for this rulemaking. My name is Amelia Boyd, and I am the program manager for the WMC. I'll be facilitating today's session along with my co-organizer, Bonnie Gregory. This workshop is being recorded, and we'll post the recording to our YouTube channel soon. The documents we'll be discussing today are available on our website at wmc.wa.gov. In the slide deck, the globe icon will take you to our website, and the YouTube icon will take you to YouTube. They are clickable and will take you directly to those resources. For attendees, if you'd like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. So before we get started, I'll take a roll call of our panelists and staff. When I call your name, please introduce yourself. Marlon?
Good afternoon, Marlon Basco. I'm a policy analyst with the Department of Health, and I support the commission in rulemaking.
Thank you. Dr. Chang?
Hi, Potion Chang. I'm a retired family physician. I'm one of the commissioner.
Bonnie?
Hi, good afternoon. Bonnie Gregory, excuse me, commission meeting coordinator, and I'm helping Amelia out.
And then Heather?
Yeah, good afternoon. Heather Carter, Assistant Attorney General, Legal Advisor.
Thank you. Kyle?
Good afternoon, everybody. My name is Kyle Kiernan. I'm the Executive Director for the Commission.
Thank you. Mr. Lopez?
Good afternoon, Ed Lopez, PA and Commissioner.
Thank you. Micah?
Good afternoon, Micah Matthews, Deputy Executive Director for the Commission.
Thank you. Dr. Domino, please introduce yourself and then begin the script.
Hi, everyone. Good afternoon. My name's Karen Domino. I'll be the presiding officer for this rules workshop. Today is Monday, March 23rd, and it is now 1:03 p.m. The meeting is being held via Teams webinar. The rule being discussed today is regarding opioid prescribing general provisions in both Chapter 246-918 WAC for physician assistants and Chapter 246-919 WAC for physicians. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-10-039 on April 30th, 2025. Ms. Boyd, please present our proposed timeline for rule development.
Thank you. Here's our proposed timeline for this rulemaking, which may be adjusted as workshops are held. If there are any questions about this timeline, please go ahead and use the raise hand function and I will call on you.
Seeing no raised hands, thank you, Ms. Boyd. Just a reminder that we have future workshops scheduled for this rulemaking, which Ms. Boyd will present later in this workshop. The next item on the agenda is the discussion of the tapering considerations section. Ms. Boyd, please present the draft language for this section.
Okay, let me get everything situated here. Hold on, please. Shuffling screens. Share this one. Okay, so we have several comments in the packet about this section, and this section is actually part of the reason why we are doing rulemaking on the opioid prescribing rules. We did receive a rules petition year before last, and this was one of the big asks, is that we update this section. There are a couple of red line comments that are in the packet. which again, you can find on our website. And then there's some new language from Washington Patients in Intractable Pain, and we can talk about that. This revision includes WSMA's red line comments. It does not include the Patients in Intractable Pains. Well, it includes their first one. They have a second one that they submitted after the workshop that we had a few months ago. But this one incorporates a lot of the suggested edits that we've received over the past like 7-8 months. And because this is part of the petition, this is one section that we have to address in some way or another. You can leave it the way it is. And this is what it looks like right now. It's pretty short. We did make a change to this early last year that added in this: not all chronic pain patients will need their opioid prescriptions tapered. So that is what you will be working on first today, is updating this tapering consideration section. Let me also pull up. I will pull up the packet so we can look at. Wrong page. Apologies. Here we go. Okay, so this is the comment that the Washington Patients in Intractable Pain submitted before the last workshop, and we didn't really get to, I mean, we talked about it briefly, but we didn't really get to talk about it at length. So we can incorporate parts of this if you'd like. Okay, here's the new one. Sorry. But that's what you'll need to talk about today. If you want it to remain as it is, which again is, well, go back a couple of steps, is right here. Or we can update it. This update has been, it's only been changed a little bit since the last workshop. We've added in a few, like this biopsychosocial assessment, which we were asked to do. And we will be, if we include this term in the tapering section, then we will be defining it in the definition section. Go ahead, Ed.
Yeah, hi. I'd like to ask someone, if there's a member of the PIP group, if they would comment, Ms. Bigham, I suppose, if they would comment on the current guidelines under particularly line 8 or number 8. I'm curious if what their commentary is on that line.
Hi, this is Rose from WashPIP. Which line 8 are we looking at? In
Current guidelines, line number 8, current.
This one?
Yes, the patient is receiving an escalation opioid dosage with no improvement in their plan or function, or in their pain or function.
What, you want my thoughts on that line?
I do.
Okay. So I'm on the fence about it, to be honest, because I don't think anyone thinks escalating an opioid dose for no measured improvement is a good idea. But on the other hand, we've struggled a bit in the places of the rules that talk about a non-escalating dose, as if people with these chronic, progressive, incurable conditions aren't expected to have an increase in pain severity in their lifetimes. They're guaranteed it. And at some point, their opioids would almost certainly need to be increased to manage that pain if there are no other interventions or options that could, in fact, improve their quality of life. So on the one hand, I agree that if a patient's opioid dosage increases and over time there's no improvement and their pain isn't managed any better, then that was a needless escalation. But it worries me that if someone is having an increase in their symptoms and severity and they get an increase in their opioid prescription to try to manage it, that takes some time to sort out where those levels are appropriate and whether they're working or not. So how quickly would there have to be a measured improvement in their pain or function for us to determine whether that was successful or needless? I don't know the answer to that. I'm not a clinician. I wouldn't presume to guess. So I guess I don't hate the sentence. I have concerns about it. This is where I land.
Thank you.
Amelia, it's very hard to see for me to see this screen because of the half of it is a third of it's our pictures, a third is what we had before. And then in small print, there's including half of the pages, what looks like.
So you can increase the
Words.
size of that screen that you're viewing. If you just hover over the screen in the middle, there's a plus and a minus. You can hit
Well,
the
that's what I
plus.
was trying to find, but I tried it, didn't work.
I mean, I can make this a little bigger.
Yeah, if you could just make it bigger, maybe
I can move
could
this
you
out
make
for
the
a second.
tapering consideration smaller. Yeah, the one that we know about.
Sorry.
So I guess I'd like to hear why. I assume that the patients in pain group have recommended these changes and why you think it makes it longer. I thought what we wrote before was pretty clear. It says it's not all required. I think most physicians know that if you don't want to acutely taper drugs in patients who've been on them CNS related drugs and people who've been on these drugs for a long period of time. And so I'm not sure. And I think physicians know it could destabilize somebody. So if you could tell us a little bit more why you feel that extra language is needed.
So part of the reason why we are amending this section is, like I said, it's part of the petition we received. So I'm going to make the petition. They submitted this petition prior to us adding this language. Not all chronic pain patients should or must have their prescription opioid medications reduced. It's not exactly like that. It just says not all chronic pain patients will need their opioid prescriptions tapered. But this request came in before this was approved, this new language. But that's the reason why we're looking at changing this tapering section, is because they do ask for other language changes within that section. Their ask is just that we add this additional language about reduced taper cut or otherwise decreased, and then make this bigger. If a patient is stable on opioid therapy and has been compliant with their treatment plan, which we do address in the revised version, and then they wanted us to say that any such reductions are a violation of state policy and destabilizing the patient by decreasing their medication, excuse me, is below the standard of care and a violation of state law. We've had advice that we can't really say things like this. So that's why the language, the revision is the way it is. We do sort of like allude to that, I guess. But that's why we're looking at this tapering section. And then in the meantime, we have received many comments about changing the tapering consideration section. So that's why we're bringing the revised version to you. And that's why we're focusing on it. at so many of these workshops because we have to address it in some way. Whether we leave it as is, we make some tweaks, we change it completely, whatever the case, we have to address it.
This is Rose from WashPIP also. I wanted to clarify, WashPIP did not submit the petition to crack open the rules. So that those requests were not our requests. We showed up when the petition was accepted because there's an opportunity here to tweak some of the language in ways that I think are both clinically appropriate and would be very helpful to patients. And I know like there's a ton of language that has been submitted and I'm terribly, I dread it. It's tedious for us to go through it all. When I think there's a couple of key things that WashPIP feels pretty strongly about that I think would be concise and clear and helpful. And one of them is, and it's in our submission here, having the physician be required to write in the medical record why tapering is required, why they're choosing to taper a patient. And that's because, as I think I've mentioned previously, I was told by a doctor they were going to taper me, and it wasn't for a medical reason. It was because they feared oversight or discipline. And other patients have heard the same, or other entirely fictional reasons why they're being tapered. If a clinician is forced to put in the record, this is the medical reason why, like I think the patient is in distress, I think they're not getting a benefit, like any of the many valid reasons that someone being tapered, that's great. Put it in the medical record so that the patient can see it and choose to challenge it if they feel it's inappropriate. Because currently a doctor can just tell a patient anything in the office and then say, chose to taper, started the taper. So we think that's a key simple thing that could be added that would just be clearer for the patient and for the medical record why that decision was made. So yes, I don't have a problem with the tapering, like the reasons why a doctor should taper. I think those are very clear. And I think when we submitted our change, we were trying to make it a little bit shorter, maybe. But I think the reasons to taper that were the previous ones are actually really great. And as long as the medical community understands them, I think they're good to go. It's just trying to make the rest of it clearer and simpler if we can. Thank you.
Go ahead,
I
Carol.
think there's Carol, yeah.
I would like to say I agree with everything Rose just said, and also on number 8, when a patient's been on opioids for any length of time, say 15 years, for a medical reason, and there is an escalation in dosage, say maybe a surgery happens, or maybe the pain is worse and there's no improvement. It does take time. Sometimes to be able to say, well, how much more is needed till we can get that patient levelized to their their pain is at a level that they can have a quality of life. So I think the tapering considerations as they are pretty concise. And I read through all of these pages, and I've had 3 surgeries in the last 3 years, so I'm trying to get all caught up. One of the things that really struck me is how we have to be careful and mindful that the Department of Health is always going to be the victim. And a lot of this verbiage, I feel like reading between the lines and not even reading between the lines, it's like, oh, I'm the bad guy here. Like I have to be paid attention to. I have to be written about. I'm the criminal. And it made me feel as though I'm like everyone's looking at me like I'm trying to cheat some kind of system. And all I've ever wanted to be is off of the medications. But we have to remember the Department of Health, if it goes to a hearing, the Attorney General is going to tell the patient that they are not the victim, that the Department of Health is the victim. So when we're writing these things, we have to remember that. So if that means that the doctor has to document why they're tapering, then that should happen. They should have to document why they are tapering, because there should be, that paperwork should be there. You can't just taper because you're uncomfortable, or I don't want to take care of opioid patients. I'm not comfortable doing that. So I'm going to taper you. So, I mean, I do think the tapering considerations are clear, concise. I don't know why they would need to be changed, but I agree with Rose. So that's my points I wanted to make. Thank you.
Thank you. So
Thank you.
I wonder, sorry, I wonder if we can take what we already have, this language here, and just add in what Rose stated, that there needs to be a document of the decision. The why, right, Rose? The
Yeah,
why.
that seems reasonable to me
Yeah,
to do
and
that.
it
Yeah.
needs to be specific, like not just I felt it was the right medical decision. It needs to give specifically one or more of those 8 reasons needs to be
Well,
in the medical record.
you have to let the physician or physician assistant make their own decision there, but we could, say not one of 8 different reasons. There may be a variety of reasons that they want to do it.
But it's got to be at least one of them. That's what the rule actually says. It needs to be one, at least one of these reasons must be present in order to taper a patient.
Yep.
So can we not require that at least one of those reasons be in the medical record?
Or I hate to require, but what I would say is something like, please signify which of the 8, one of the 8 or multiple of the 8 reasons are the reason why you don't want to taper. Is it don't want to taper, or you will taper? Yeah.
Will.
There's someone on the thing with
Yeah,
the
it's
hand
Jib.
raised.
Go ahead, Jib.
Thanks, Amelia. Hi, Dr. Domino.
Hi.
Folks on the call. Just want to call attention to Wisma's comments on this section later in the packet. We've got a cover letter talking about the need to simplify these rules and streamline them to make them easier to navigate for physicians. And so the way that we suggested approaching this would be to move requested by the patient up into the paragraph, and then or clinically indicated, to Dr. Domino's point about giving, there are a number of reasons why tapering might need to occur. And so that gives some flexibility to the clinician instead of being so prescriptive. And that's in alignment with our broader sort of philosophy about how we feel the medical commission should be approaching this. I'm not speaking to the suggestion necessarily around documentation in this particular section. I think it definitely merits discussion, but I did want to point out that there are 41 references to document or documentation in the rulemaking. And so adding another one, I think, is just going to add to the problem that we've been trying to raise. So again, just to sort of recap, not necessarily pushing back on the merits of including a documentation requirement in this section, but did just want to make sure people were mindful about the volume of documentation requirements that already exist.
Hey, Jeb, if we can find another one of those requirements and kill it, can I have this one?
I would have to look at the draft, Rose.
Fair enough. Fair enough.
There's Carol, Jason.
Yeah, I'm sorry, Jeb, you were, what are you talking about? Where you say, oh, well, there are other places, because I've seen that in a lot of the comments. Well, this is a standard. This is already a standard. But where in another section would this already be told to the doctor, this is what you need to do if you're going to taper? Because the problem is now with doctors retiring is that new doctors aren't comfortable with patients who are on opioids. So it's important that we have some kind of standard, that there's a measure that you want to taper this patient at a minimum in the record, in the patient's record, you say why. I don't think that's an overwhelming burden to ask.
And I agree with you, Carol. Thank you for that comment. And I'm not saying there are documentation requirements around tapering that already exist in the rule. I'm saying there are a lot of documentation requirements. And so if we're considering adding more documentation requirements, where can we make this simplified in other areas?
Yeah, I'm going to jump in here. It is occurring to me that requiring the physician or physician's assistant to add the reason for the taper is probably going to be helpful for both that patient going forward and future providers. So that in the medical record, when a future provider is trying to figure out why was this patient tapered, what was the issue, if the current physician is forced to say, this was my concern, this is why I chose to taper this patient at this time. Going forward, the next provider who the patient sees will see it right there in the record. We were concerned about you weren't getting an increase in function. We were concerned about you might be asking for early refill. Whatever the concerns may be, that's going to improve the quality of care and improve the quality of the healthcare they're getting going forward. So I am totally on board with these need to be simpler and shorter if we can make it happen. But I think this one is critical for both safe and careful patient care.
Any other
Okay.
discussion? Any commissioners have any discussion?
This is Dr. Chang. I think particularly for number 8, that's I can see there's some confusion, but I want to call out that this is regarding chronic pain, not acute pain. So some of the comments say that, yeah, I had surgery, then therefore the doctor refused escalations of pain medication. That's acute pain after surgery. That's a different issue. I think probably we talk about number 8 is that if the escalations because of the longstanding chronic pain that's already identified, not because of surgery, that probably will make more sense, for that part.
Dr. Stanos, I think you were first.
Yeah, no, thank you for having me. I agree with what's been said. For number 8, maybe it's clarified that it's the patient is receiving an ongoing escalation in an opioid dosage with no improvement in their function. Because I agree that, there's sometimes it takes time to get someone appropriately titrated up, and especially if it's, advancing disease. And maybe that's just a simple way to clarify that. And then if the other recommendation is for number 1, I agree. We really want to make this less. There's a lot mentioned about documentation, but in here it's pretty. I thought there was. It says relying on medical decision making and patient-centered treatment, the physician shall consider tapering or referral for a substance use disorder evaluation, and maybe someplace in there it's in document appropriately. Just about that they should document appropriately. And because I think it's understood that you would want to be documenting while you're making decisions. But is that a softer way just to include it there?
I mean, I like that.
You know
And
what I'm
then-
I
saying?
like
Just
that too, yeah.
the physician shall consider tapering or and document reasoning or consider referral for a substance use thing, something like that. because I know as a clinician, we're always, hopefully we're documenting anything we're doing. We want to try to explain it, but
I think that
versus
sounds
a
appropriate.
shall, putting something like that in.
Well, and there is a request from WISMA to change the shall to should, and since the title of this section is tapering considerations, there's no
Yeah.
like how do you prove that you considered, you know what I mean? So
Yeah. Oh,
I mean,
thank you.
we could change this to should, I think, but
I think should's fine. I guess there was Jeremy Ganoza.
Yes, can you hear me well?
yes.
Yeah.
Yeah, if you could, another thought about interpreting that line 8 that you've been, could you scroll back to that?
Sure.
Which I'll explain, but which that might be addressed by adding patients receiving escalation in opioid dosage with no improvement or maintenance of their pain control and function. I could see a scenario where someone had an increase in their opioid dose, and at first glance, someone says, well, this happened and your pain remained at 4 or 5 out of 10 with good function. You didn't have any improvement. Well, if you take a closer look, maybe they had 3 months of worsening pain, and it took a higher dose to simply return them to a baseline level of pain and function. If that makes sense. Someone could see that there was some adjustments. They didn't improve, but actually what they were able to do was simply maintain their quality of life.
So if you can
Oh.
suggest to Amelia how to phrase that then in number 8.
Patients receiving maybe that ongoing escalation in opioid dosage without improvement or maintenance of their pain control and function.
This is Rose. I really like that. And I also wanted to point out for those of us living with chronic pain, it's not linear. We don't have like 10 decent days and then a couple, like it's up and down constantly. There is no, my pain was at a 5 for the last 6 months. That does not happen. We wake up with bad days, we wake up with good days. So trying to gauge whether maintenance of pain is consistently happening, well, our pain levels are never the same day to day, most of us. So that'd be challenging on a good day. At least with this language added of with no maintenance, that is inclusive of some good and bad days. I like that. It's a lot more flexible than what we had, I think. So thank you.
Appreciate that.
And there's CJ.
Carol.
Yeah, it's Carol. Thank you. And I agree, Rose. It's not linear. One day might be great, the next day might be really, really terrible. And the thing about the surgeries is when you add a surgery in, it messes everything up. So you might have extremely bad days, and it may take a long time to get back to your baseline. So I think having flexibility in that, and also if your doctor were to retire and you had a new doctor, you have to start all over again. And so I think it's important that that's being changed. And I did notice in all of these things that I was reading is the changing of the shall and the should, and the encourage and the expect. So shall has teeth and should is more like an encouragement. So what is the thought on changing a lot of the shalls to should? Like why are you deciding to do that?
So I will just respond to that for this particular instance. It's because this section, like you can't, like, how would a doctor I mean, I guess they could just write down that they considered tapering a referral. But again, that goes back to Jeb's comment about all the documentation requirements. So the name of this particular section right now is tapering considerations and not requirements. So there's no requirements in it, even though there's a shall in it currently. So that's why I think that in this instance, it can be changed to should.
Okay.
As to the
Thank
rest
you.
of the requests to change them from shalls to should, Jeb could probably give you more insight into why they're requesting that. If he's still on.
Well, I mean, it would depend. I mean, there's so many. I mean, it would, and I'm going to send some notes in on each specific one. So I wouldn't expect them to answer it now, but thank you for answering it on this one.
And then Dr. Stanos, I don't know if you saw that question from Micah in the chat, but he asked, is documenting the tapering discussion and decision in the record current standard of care in your practice?
Yeah, I'm sorry. The question is documenting why we're tapering standard?
Like putting it in the record, yes.
Yeah, I mean, I think we would encourage that. I think if you're going to be making a change, you would want to document it, not just do it, right? I mean, I think yeah, I think that's just part of the typical documentation, if I'm understanding what he's asking.
Yeah, it was really during that discussion about are we going to make this a should or a shall and adding that stuff in. It's one of those, okay, is the reality current standard of care out there that you're going to document this anyway, in which case there's not a loss in going to the should. But the other piece is, if everyone's doing this already, then do we need to focus as hard on the requirement? Because and to address Carol's comments, while it is a rule, we do want to acknowledge how physicians and physician assistants practice, where they're already motivated by a number of factors to practice to the top of their license and to the best standard of care that they can. We're trying to establish a floor with rules. And so just trying to make sure to keep all those factors in mind.
Yeah, and I would say, I see where you're going, Micah, is that I like using should because I do think it's standard. I will say, because I review a lot of the primary care notes, still the notes are kind of all over, that it is good to see when a physician's obviously explaining why they're doing something. And most of the guidelines and things that talk about tapering talk about documenting why you're doing it. So I think the communication piece is important.
This is Rose. One of the other reasons we feel pretty strongly about the documenting the reason is in a world where we're having private equity snap up clinic chains and declare prescribing limits, when the physicians in those systems are forced to taper their patients maybe against their will because of that's what their employer is demanding, if those physicians can then document or are forced to document why they're choosing to taper a patient when they don't want to, that leaves the physician with some legal backing, right? Like if the state rules say you must document your decision and their decision is not up to them, well, they got to decide how they're going to handle that. And their ownership needs to understand that as well. I know it's not a great solution to all that bigger problem of clinic ownership, but it's something. It's something.
Okay, so I did a little rework. So what are your thoughts on just changing the whole section to say what's on the screen right now and eliminate everything else?
I can live with this should there. I'd rather it be a shall, but I won't battle on to die on the hill of it being a shall versus a should.
And you're talking about this should, right?
Yes, I am. That's a pretty strongly worded should. I like it.
Commissioners, what are your thoughts?
I'm fine with this one.
Yeah, I think some people may like more detail with the number of things, but to me, it makes it shorter. It relies on, clinicians' considerations, and that's rather than micromanaging and specifying particular reasons, because there are a bunch of reasons that may not fit into those ones that we considered before, and it simplifies it.
I think one of the biggest concerns that I have, and I would echo what many of my, if not most of my clinician colleagues would say, is that they worry about as Dr. Domino had pointed out, and used the word micromanaging of their practice. And I think that we need to always be continuously aware that the relationship between the physician and the patient, at least it used to be sacrosanct, I'm hoping it still is, and that what goes on between the clinician and the patient is an arrangement between the two of them and should not be dictated by the way that someone decided in Olympia of how it should be done. And so my concern is to leave things as simple as possible. And I realize that when you leave it open, there's a lot of interpretation. People are neglectful. I get it. But also the bringing the pendulum into the other direction of micromanagement, I don't think is a wise decision either. So using the term, not using the term shall, I think is a great thing. But I think that the more reasonable we make it, the better compliance by physicians.
So, Heather, can you just weigh in a little bit on your thoughts on this change, please?
On changing let me pull this up, the should and shall. I mean, yeah, so you had shall consider, consideration. Let me turn my camera on, sorry. Consideration isn't something that happens in your brain. So I think you're right. It's not going to make a whole lot of difference in this instance, the should and shall, because you consider it, but there's no, if you add documentation, then that's going to be the hook, I guess, that the doctor needs to do.
So this says should. I'm going to ask a controversial question. Should the second one be a shall?
If you want to make it a requirement, then it would need to be shall. If you want
But
it
it's
to
under
make
considerations. So to me, it's
We're
Well,
probably
then maybe
gonna
you shouldn't say consideration, because I think it should be a shall.
So I think we're going to change the name. If we make that a shall, we'll change the name to just tapering. It can just be called tapering because it's just about tapering. Yeah. I mean, commissioners, do you want to leave it a should?
I like should.
Okay.
So the first should, this is Heather. So the first should is saying, okay, physician, you need to consider tapering or referral, and when the patient asks, or if there's a clinical reason. But if you do taper, you need to document it. Then that second sentence should be a shall.
I agree.
So if you had a disciplinary action for someone who tapered for the wrong reason, and you wanted to discipline them, if they don't have this indicated in the record, you're not going to know.
I'd like to echo that.
Okay. So I think I should change this sentence a little bit. Tapering is indicated?
Initiated.
Initiated. Thank you.
And with removing, this is just a question I have, maybe it is included. So you have requested by the patient and clinically indicated. Are all of those others in the list a clinical indication? non-compliant with the agreement, misuse.
So I
I
think
just want to
what
make sure
you're,
we're not
I
forgetting
felt
those.
so.
Okay.
so could we could we say clinical, could we still keep the list and say including but not limited to the following
I'd like,
some way?
well, I'm worried about having just such a detailed list if we're trying to make things,
Okay.
you know, easier for people to and trust our physicians. Dr. Stanos had his first hand raised though about it.
Yeah, I don't want to sound like a hypocrite because I agree with making this simpler, but I think this is taken from the HHS guideline for reasons for tapering. So could you put examples include?
Mm-hmm.
Because it is exhaustive, and maybe that's it, because it is pretty close from my recollection to the HHS in that these are the kind of standard reasons why people should be tapered. And so it's just more of a useful thing. Separate from everything else that I do agree we should try to simplify this and have less words, but it may just be more for clarification.
And that
Or
makes
that doesn't
sense.
matter if you don't want it for, but I know that was the classic HHS from a number of years ago. So at least we're kind of using the same language as other guidance.
Go ahead, Rose.
Yeah, I was gonna say I agree with Dr. Stanos. It doesn't have to be this is the definitive list, but it's really helpful to have these reasons present. Especially if someone is like, I'm not sure if what I'm seeing meets, the criteria, and here is the defined list of clear reasons why someone should consider tapering a referral. I really like still having it here. If there's a way to do it more concisely, great, but I'd like to keep it if we can.
Okay. Go ahead, Jeremy.
Thanks. I think the key line that is most important to get people's attention, maybe even get them to read the rest of the document, is that first line. And in terms of kind of person-centric language, would it make sense to say not all patients with chronic pain? Might add a word, but it seems to me that's a little more person-centric language.
That sounded good.
Yeah.
Yeah, I like that better.
Jeb?
Yeah, thank you. I like the direction this is going in. Just to answer, I've lost her name. I think it was Carol. Question: if everything is a shall or a must, then any deviation is a potential violation that doesn't allow for clinical judgment. So I think we would really appreciate the first should, and then if the documentation requirement is less clinical. So if that's something you just like to see, I think that makes sense. And then if that language is there as examples of clinical indications, I think we'd be more comfortable with that.
Thank you, Jeb.
Yeah.
Okay. So I think we've done some good work here. Does anybody have any other issues with this new language or suggestions to change what we have?
If I could say one more thing about it, because I think it's a good move in the right direction. I think, and we touched on this a little bit, but I think, one of the reasons for the tapering is someone not being comfortable or someone feeling they actually needed to do that to follow external guidelines. So one thing I'm thinking about is a line that says it's generally not appropriate simply to taper due to external guidelines without considering the individual considerations of the patient, I think, which has really been a problem for many of our, and I'm an osteopathic family physician, by the way. But it's just
Sorry
a thought
for
that
this,
there's still an opening for someone to document that they're following guidelines, and that's their reason for documenting the taper without documenting anything individual to the patient.
So we do have this sentence already in the previous revision that just says patients who are stable on long-term opioid therapy and following their treatment plan should not be tapered solely to meet guidelines, policy limits, or dosage thresholds. So we can include that in the new, like right where it is right now.
I think we should include that, keep that right where it is. That's my point. Sorry, but yes.
Well, that's an easy one then.
So, sorry, I'm doing a lot of editing here. So, sorry for the scrolling. I know it gives some people triggers a vertigo. So before I get to you, Jeb, sorry. Commissioners, what do you think about adding that sentence in there?
I'm fine with it.
Yeah. That's good.
Agreed.
Okay, go ahead, Jeb.
Agree that patients should not be tapered to solely meet guidelines, policy limits, or dosage thresholds. I guess my concern that I would want to raise here is these rules are applicable to a physician's license. So it's on them to follow this. Oftentimes it's been raised on here, there will be their employer, and whether that be a large medical group or a hospital, will have policies, and you're putting in a physician in a place where they have to follow these rules or not follow their employer's requirements.
So this is just the way that I see it as someone who's dealt with these rules for 10 years now. I feel like that statement puts some support behind the physician when they are dealing with, when they're up against guidelines or policy limits that are being set by like a clinic owner or something like that. That's just my point of view on that.
Yeah, I think that'll vary widely
Mm-hmm.
by employer.
Well, we are all employees these days,
Mm-hmm.
and they do pay our salaries, and they fire us too. Dr. Stanos?
Yeah, I don't know if like I'm having an existential crisis here, but it says following their treatment plan should not be tapered solely to meet guidelines. What guideline would tell you to do that? It's almost like an inappropriate guideline. And it's almost like I don't it because
But it's not just about
it's
guidelines, it's how they're interpreted. Remember when the CDC guidelines came out about 2016, so many doctors stopped patients on opioids that CDC had to follow it up with a letter and saying you shouldn't do that.
Oh no, I understand that.
misinterpreting our
It's more
guidelines,
it's
right?
almost like misapplying a guideline.
Right.
Because like you could have a hospital, a clinic, and say, Joe Blow's clinic has decided that their guideline is we will not write opioids for any patient. That's our guideline, or it's more like a policy. But I would say it's more like misapplication of guidelines was what happened with the CDC, right? It's because it kind of
Right.
makes like, yeah, you could just make up your own guideline. Then a hospital could say, well, this is our guideline. We just don't want anyone
Well,
to be on
that's what
pain
they
medicines.
do. Yeah.
But that's not appropriate though, right?
That's a policy.
But is that policy appropriate? I mean, my point is maybe it's giving the green light to these policies that aren't accurate.
Well, we could remove the word guidelines and just put
Just say policy limits,
or
external
dosage
policy limits or
thresholds.
something. So
Yeah,
my point is like a
external.
guideline is something that's evidence-based and approved and everything. Maybe that's it. I just got a little, okay, tape it solely to meet a policy limit, right? A policy limit or dose thresholds. Because
I mean, Ms. Rose, we'd like to think those guidelines are all evidence-based, but the state law that requires 120 MED guideline referral, that 120 MED limit was picked out of people in a room because they didn't have any evidence. So like if they actually say it in the paper, they just, went on the experts in the room and declared a number based on no evidence whatsoever. So I think it's trying to it's trying to address that we do have some clinic chains that have declared blanket MED dosage limits. And yeah, they're inappropriate, but they're out there. So that would
But
give.
we don't really have anything that we can do as being part of the medical commission. I mean, that's more of a hospital or some kind of other thing. We're just dealing with individual practitioners who are employees. And, you know,
Yeah, I'm just saying it would give those doctors who are employees a defense to say, like, according to my licensing board, I can't do this stupid thing you're asking me to do because it's against the state law right here. I don't know how effective that would be, but
I agree
I'll
with
leave it to you
Rose.
guys.
I mean, I agree
I'll
with
leave it to-
Rose. It gives the doctor, when the patient files with the commission a complaint, it gives the doctor the reason why.
I was going to say, I'll leave it to you guys who are clinicians, who are working for other organizations to determine whether. I like adding this statement 100%. Love it. Love it. Whatever language you end with, I'm going to be thrilled. If you don't think it's reasonable to add the guidelines or policy thing at the end, then I trust you know better than I would, because I've never been a clinician. So what do I know? But thank you very much for adding this at all. I love it.
Okay. So commissioners, do we like this as it looks now? Again, we've changed this first paragraph a little bit, added this sentence in about patients who are stable, removed guidelines, changed the shall to a should, added in some of this language that WISMA likes. Let's see. And then the reason for tapering shall be documented. And then we kept the examples of clinical indications.
I'm fine. Thank you.
Dr. Domino,
I'm fine too.
Mr. Lopez.
Yes, I'm all in.
Then Jeb, you have a comment?
Just took me a minute to think through some of the comments that were made about this giving physicians a tool to push back on the leadership, at wherever they're employed. And I'm not a physician, but my sense is that the ability for a physician to push back on a hospital or other very large employer is going to be very limited. Even if you put this in your rulemaking.
Mm-hmm.
So I liked the direction this was going in, but I think this is going to put some physicians in a difficult spot.
Well, I think part of this language is, it may be, I'll have to look for sure. It may already be in our interpretive statements, because we do have an interpretive statement for physicians and physician assistants related to these rules. But I would have to go back and look to make sure. The commissioners, do you have thoughts on that comment?
Have to go back and look.
I guess my question is, how would you envision why physicians would push back, I guess? What is it about the statement that would make a provider, physician, or PA push back and say, oh, that's so unreasonable? I'm curious.
Not necessarily saying it's unreasonable. I'm saying you are putting a requirement on an individual license when this is such a bigger issue than that one person, in that they might be employed by a hospital or a health system or a medical group that has a policy in place. And they're put in a position where they have to follow this rule or follow what their employer says. Whereas I don't know what. Yeah. I liked the direction before better, but.
Kyle, did you have a comment about that?
I do. Jeb, as long as we're talking about this, I guess my question for you is, what's the alternative? Like, we see these issues quite frequently in complaints as they come in from patients talking about forced tapering regimens, and that's usually what it is. And so, we don't have authority or jurisdiction over hospital systems or practice group administrators to the extent that they're non-clinicians. And so I guess I would ask, what's the alternative? Respectfully, of course, but I don't, the commission has a very narrow jurisdictional mandate here.
Right, and that's the challenge.
That's the tension. That's the tension that I think you're talking about between these folks who are kind of saying this is going to be the policy, and it's kind of one size fits all, and that tension is with the patients who, that may not be an appropriate clinical remedy for or clinical option for. So what's the alternative?
I don't know what. Well, the medical commission can't do anything to help physicians that are put in this position. So in terms of alternative language, this is something I would have to take back to actual physicians to ask them how comfortable they are with this. But is it a problem that can be solved? Like, I think misapplication of guidelines made more sense because that's more on the licensee. But to ask them to, it's tricky because, the employer might have an inappropriate policy or guideline. But I just don't know how putting this is going to solve that problem. Like when you're putting the onus on the individual license.
So Jeb, do you want to just put back guidelines? I mean, there are all sorts of guidelines. I mean, many of them are just people in a group, as people are saying, coming up with some expert opinion, and they call it a guideline, as opposed to meta-analyses of randomized controlled trials. So would just going it the way it was, having the word guideline in there, rather than just policy limit, would that be better? Is that the language you like better?
I'm not in a position to be able to sort of sign off on this, and this isn't going to be final as of today.
Yeah, no, it's not.
Yeah, so we can keep it here, and I can take it back and consult. I see Dr. Stanos has his hand.
Yeah, no, I understand we're in this tough bind that I don't agree if the hospital made that and we can't block that, but maybe is it to meet a predetermined policy limit? Like it's almost like it's not patient centered. Does that at least make it like you're just doing it willy-nilly? Because the rest of this we're explaining it needs to be done for the right reason. I'm just throwing that in there. It's just more wordsmithing, like predetermined policy limit or dose threshold. If that helps it, to make it like it's a limit that's not really related to the care of that individual patient. It's just a random, like predetermined policy limit, something.
Jeb?
I think that's better, yeah. But I think, let us think on this a little bit.
Yeah.
I'll add it, and then if I can spell today.
But I'm sorry, but I thought the interpretive statement said that you maybe it's more related to that you're practicing below the standard of care if you refuse to take a patient back and things like that. Are you implying that this could help? This is almost kind of what the interpretive statement said that about forced tapering. I don't have the document in front of me, but
that's what I need to go look at
and
see what it says.
The interpretive statement, would that be the one I have here is opioid prescribing and monitoring for patients. And then the last line just says ending opioid therapy or initiating a forced tapering of opioids to a particular MED level for reasons outside of clinical efficacy or improvement in quality of life and or function or abuse would violate the intent of the rules.
Yeah, I thought it said something to that effect. Yeah.
Yeah.
I just need to go back and review it. Okay. All right. So are we okay with this language? And like Jeb mentioned, this is not, I mean, you're working on this today, yes, but we will revisit all sections of this rulemaking, excuse me, on either the last workshop that we hold, which may not be the one that's in the packet, it may be farther out than that, but or we will go over it over 2 workshops depending on how quickly we get through things. So that we'll be revisiting this. You can comment up until the date of the hearing or the week before the hearing. So, and then you can comment at the hearing. So it will be a while before this language is adopted. So there will be plenty of time to request changes. Rebecca, did you have a question or comment about this?
Oh, I was just going to suggest that we add where it says the physician should consider tapering or referral to a substance use disorder evaluation, maybe also meant like a referral to mental health, because I think a lot of the concern here is that people with forced taper sometimes become destabilized and suicidal.
I mean, that's true. I think we have this language in here because we require them, right? We require them in the rules to refer. Maybe somewhere. What are your thoughts, commissioners, about adding language about mental health evaluation?
I had to think about that. The reason is that while it's all good intention, but in my past and when, I'm suggesting tapering, and then also adding mental health referral and the patient's perceptions is that, oh, you're thinking my pain is just all in my head. That's why you're putting mental health, as a requirement. So that I think it's a good idea, but I'm not sure where it ends on this.
So leave it out for now.
I'd leave it out for now.
Okay.
It certainly could be added to the interpretive statement
Mm-hmm.
when that gets reworked.
Yep. And those will be revised once we adopt new rules. Both of them will be revised. So.
Or is that one they should separate from the behavioral health one? Because I understand the kind of the stigma with that and taken the wrong way. But is it referred to a pain medicine specialist, right?
Mm-hmm.
If you're in the primary care clinic and you're struggling, and the person, you don't know about the taper and that. Again, I don't know if that opens a whole can of worms or not, but it seems to me that may be more common. It's not that they're doing it intentionally; they just don't know what to do. Or would that throw this whole thing off, which I don't want to get in trouble for doing.
The commissioners, what are your thoughts on that comment?
Yeah, they should refer to pain medicine. I mean, they could. Don't we say that somewhere in here anyway?
Mm-hmm. Oops. We don't say refer to a pain management specialist, so, and not in this section.
Wasn't that for a dose over a certain
Mhm.
number? Yeah,
At
amount
120.
that it was. Yeah.
Yeah. Go ahead, Jeremy.
Thanks. Yeah, actually, just one of the, if you could scroll down to just one of those reasons for tapering, the number 2, the patient is non-compliant with the written agreement. I think of patients who've maybe missed one visit or, had one hiccup in their treatment plan and then been dropped. Could we consider language like, or does this, or do we need to keep this verbatim? Could we consider the patient has a pattern of consistent noncompliance with the written agreement?
Thoughts,
This is
commissioners?
This is Rose. I'm going to say that this is tricky space because some of these patient agreements are very prescriptive and some of them are not. And so if a patient has a a bad UDT and it's a fluke, like, yep, that means they're not compliant with the agreement because the agreement says you shouldn't have a bad negative screening test. But missing an appointment, man, a doctor would have to be a real jerk to taper a patient because they missed an appointment. I just don't. While I've seen some pretty heinous behaviors, I've never seen that happen. I don't know if this is a space where we want to be more prescriptive than this. I don't know. I would ask the people among us who are clinicians to weigh in on this because that just seems like a pretty gnarly space to dive into.
Yeah, but we have seen situations like that, and I think even one abnormal, and I've seen a number of guidelines say one abnormal urine test is not enough itself, right? That needs to be followed up with confirmation and a careful history, that kind of thing. So it seems that I think a number of places have been pretty quick to drop people. So, but if that needs to follow some external standard that we're basing this on, I understand.
This is an issue I can reach out to. I mean, I can reach out to Dr. Lee and see what her thoughts are.
Well, I mean, I'm not sure I know it's a long document, but definitely the newer language is around not abandoning patients, and you wouldn't kick someone out of a clinic for one abnormal urine screen. So I don't know if there's anything somewhere else that talks about that you shouldn't abandon patients, and you need to, if they have a substance abuse problem, you need to address it and get them the right resources. Again, I'm not sure if that's someplace else in here,
Perhaps.
And even so, I think it's fine to reiterate stuff like that if it is, because oftentimes, when physicians look at the rule, they only look at the one section that's applying to whatever situation they're in. And so sometimes it is worth repeating in a section. We do that from time to time. So, but I'll reach out to Dr. Lee and see what her thoughts are on changing that. Because I do know that back in like 2018, we did have several patients that complained that they were dropped because they missed an appointment or, something like that because they were taking that statement, the patient is non-compliant with the written agreement really literally at that time, I think. So I haven't heard of that happening in a while, but it did happen previously. That's probably why I mean, yeah. So I will ask her what her thoughts are, and obviously we'll bring this one back for sure. We can
If I
talk about
can
it at the next workshop if we need to. Go ahead, Rose.
Yeah,
Sorry.
I say if I could suggest, rather than trying to, maybe we just kill this sentence, kill it as a reason to taper a patient. Because everything else that remains is still like there's evidence of abuse or you've had an adverse event. Like there's all some really great other reasons to taper a patient. Maybe we kill the like you missed an appointment, take it off the table as a suggested reason to taper a patient. The agreements, I think, are less important than they used to be back in the day. Rather than trying to make it more detailed than it is, I think we should just kill that one. That's my opinion, having given it a minute.
Commissioners, what do you think? And then if Dr. Stanos could also weigh in.
Actually, that does make sense. You know, basically, if you look at, you know, now the number 2 and number 4, 4 does cover the part, the so-called, you know, non-compliant part, if they're misusing, abusing, and that's already addressing that part. So if you're talking about other non-compliance, you know, like missing appointment, which is taking a literal, and I can see that because sometimes a patient has to travel long distance, or, you know, or getting stuck in the traffic, which is not their fault, but they miss appointment, and then yet they get the that just doesn't make sense, you know, because the clinic is making it very literal. So I'm okay with that.
Dr. Domino? Ed?
Where is that specifically set? Is that part of the non-compliant with written agreement?
Mm-hmm.
Or is it down lower where I can't see that you've missed an appointment?
No, it doesn't say that. They are just taking sometimes. Yeah, what they were saying is that's non-compliance, is missing an appointment.
I'm fine with striking that, because to me, misuse, abuse, substance use disorder, and diversion fits misuse and abuse, right?
Ed, do you have additional thoughts?
No, I think I agree with all.
And then Dr. Stanos, do you have any?
Well, yeah, I agree. I think it's better to take it out, because the good thing is there's no standard agreement anyways. So it's just get it out of there. Yeah.
Okay. Go ahead, Rebecca.
I was just going to share a thought that on it's now number 4, I think, the patient experiences a severe adverse event or overdose, that at that point it's kind of too late to consider tapering, and that maybe we could consider changing it to the patient is at risk for a severe adverse event or overdose.
So I would love to hear more about that, changing it to that.
No, I don't like that at all. Sorry, just going to jump in there. The intent, I think, of this one is if someone is taking their prescription medications as prescribed and there's an adverse event, sometimes that can be like people got their medications confused, or they got the time confused, or they forgot when they last took their medication. If someone accidentally has an adverse event, that's a reason to have a very serious conversation with that patient, but it is not necessarily indicative of someone falling into a substance use disorder. If we change this to a risk, well, every patient's at risk of an adverse event, because every time they take an opioid, there's a risk. And trying to narrow down and define what that level of risk might be as a reason to taper an otherwise compliant patient makes me very, very nervous. Sorry, thanks.
Commissioners, do you have a comment about
leaving
that?
it as is.
Okay. Okay. So this is where we're at right now. Commissioners, how do you feel about this? Are we good to move on to intent and scope?
Amelia, there was something in the chat that came up briefly.
Okay, I will take a look at it.
Carol, this is Rose. Did you just paste the current version of this section in the chat for some reason?
No, that's the interpretive statement.
I just put the interpretive statement in there for tapering.
Ah, okay.
And again, that will change once rules are adopted, that the interpretive statements will be reviewed and changed. Okay. So are commissioners, are we good with this now?
I'm good.
Okay.
Likewise.
Are we able to move on to the next item in the agenda?
I think so. If you're all good with this, then
Okay.
yes.
The next item on the agenda is the discussion of the whatever it is, intent and scope section.
Mm-hmm.
Did I get that right? Yeah.
Yes. So we've had a lot of requests to change our intent and scope section. It's very, very long right now, as it is. Let me go pull it up. Oh, please.
So I have a question while you're opening that up. So I printed all these pages, and they all read the same date and the same time. And I just wondered how you determine which one is the latest copy.
So I'm not sure what you're looking at, but
The intent and scope. Well, I guess intent and scope may only have two. I have a draft
right.
and a
So
revised. Maybe
there's
that is the
usually
only one.
it's usually tagged at the top, draft as
Okay.
of whatever day. So if it has a different date that's older, it's probably an older version.
Oh, all of mine say March 6th, but okay, we'll just go from there.
So it may not have changed between well, our last one was a month ago. So I think the only thing I changed in here was like a little bitty, just a little tweak. So there's probably not that much difference between the one on the 23rd and the one now
Okay.
that we're looking at.
Right.
Yeah.
Thank you.
Okay. So I was just gonna real quick show you how long, I'm not gonna read this, but how long it is right now. And then we've had a lot of requests to make changes to it and additions to it and things like that. And so what we tried to do here is incorporate a lot of those comments and make it shorter at the same time because it was pretty repetitive with some of the changes that we were making. So, and we may need to defer till the next meeting, but we can start to work on this to some degree. And I just want to remind you that what's in the packet, this is the revision. Everything that's underlined is the revision. And then everything that's struck out at the bottom is what it currently is. And then I just had some comments that we can look at WSMA's suggested edits in the packet. And then I had a question if we should add information about the biological assessment or the biological psychosocial assessment, which is very hard for me to say for some reason. We are going to define this if we include it in the tapering sections, which we did not today. So we will not include it in the definition section if we don't mention it in the tapering sections, which right now we're not going to. So, okay. Let me go pull up WSMA's suggested edits.
Amelia, are you saying that everything that's crossed out in the draft
right,
as of
all
March
this
6th, that everyone's considering taking that out?
So we're considering what we're doing with this particular section is deleting everything that's there right now and redoing it completely. And the stuff that's underlined in red, not crossed out in red, but underlined in red is what is being proposed to replace what's already there.
Well, I mean, the teeth in this intent and scope is just deleted when everything is taken out.
So the intent and scope is not, it doesn't have any teeth. It is not requirements. It's not regulations. The
But
intent and
isn't it
scope.
the intent and scope of the commission to define the opioid prescribing general provisions? Isn't that the intent and scope of the intent and scope?
But this section does not set out regulations or requirements. Not this
Okay.
section. All the other sections do that for the most part, but this section doesn't. It's just telling you what the commission's intent is and what the scope of these particular rules are. That's it. We're not ever going to enforce anything in the intent and scope section because it's just guidelines. It is not enforceable. So if you see something in here already that you feel did have teeth and it's not in the remainder of the rules where all the requirements and regulations are, then we can possibly add it in to wherever it needs to be, wherever it's appropriate. But yeah, this section, it shouldn't have anything enforceable in it.
Amelia, can you scroll further down so we can read the whole thing?
Sure.
Thanks. Good.
Hey, Amelia, did you want to maybe clue the attendees in basically to the differences between our intent and scope and all the other prescribing boards and commissions' intent and scope, just for perspective?
So I don't know about everyone's intent, all the other boards and commissions' intent and scope, but ours was more about just explaining what we feel should be, how patients should be treated and things like that. So I mean, I think Becky's here. She can talk about osteos if she wants, or you can explain what your understanding is, but I'm not familiar enough with them to speak on that, unfortunately.
Sure. And if Peggy wants to jump in, that's fine. But I can just give examples like, between us and podiatry, and the intent and scope section in other boards and commissions is generally fairly short. It's simply, this is the scope of the rule, this is the intent that we're going forwards, and it's maybe a paragraph. And so, I mean, if osteo differs, I'm guessing it was part of the whole process of developing these back in 2017. But by just to support what Amelia was saying, by shortening the intent and scope, we're not losing anything in the rule. We're simply removing excess language that we cannot enforce.
Jeb?
Yeah, just speaking to some of the red line that WISMA offered up, it was to bring it more in alignment with what the other boards and commissions did. I am curious. I haven't had a chance to sort of do a side-by-side with the rest of the rule, but just looking through it right now, it seems like a lot of this is already in the rule. So I don't see the benefit of really sort of sandwiching it all in the beginning in a section that's not enforceable. And we did include language, and I apologize if I'm missing it, or there was old language in there around physicians should not fear disciplinary action from the Commission for ordering, prescribing, dispensing, or administering controlled substances, including opioids, for a legitimate medical purpose and in the course of professional practice. That is language in this section that we like.
Sorry for the scrolling. This is WISMA's suggested edits. They wanted to keep this and then add this sentence and then keep the very first sentence in the intent and scope section. And I think you redlined everything else. Yep.
Correct. Yeah.
And I don't know that that part is included in. Sorry, it's so small, Dr. Domino. I'll talk about patients, prescriptions. guidance. Mhm. So, I mean, this would be a good place if you want to retain this. This is a good place to add it because this talks about the physicians.
You know, I actually, there's so much to read that people just don't read it. I mean, they look at the big picture.
Sure.
I think the stuff in black on page 4 is absolutely important. That's what we want to get around. And I'm not sure a lot of that stuff is what's already been said. And couldn't it be reduced to a paragraph and have, something short? That's just my feeling about it. It just seems repetitive.
So just real quick to answer that, Dr. Domino. So I think it might be a good idea for us to come back to the intent and scope section after we're done with all the other sections, because then we would avoid a lot of repetitiveness. Sorry, that's really hard to say. But I will add this back in for sure. Go ahead, Dr. Stanley.
That's an important statement. I mean, that's really important. That's what we want people to know. This other stuff just seems like a lot of description that everyone knows anyway.
Yeah.
And
Dr. Stanos?
Yeah, I agree. I'm glad that hopefully you can put that back in because I think it does set the tone, and maybe that's the reason why you have an intent and scope. I know you want to keep it short as possible, but I think that's good to include that. The only reason why I said about putting biopsychosocial is that's just more general how we look at how you describe someone in pain. So if it's too much, then don't include it. But I just thought that kind of sets the tone about pain management.
And again, this in black over here is already in the intent and scope section. So it's not like you're adding something that hasn't already been out there in the world. So.
I mean, the whole biosocial thing is very important. I don't mind something about that. But there's other stuff that I felt was not important.
On the intent and scope, does the Department of Health encourage physicians to be knowledgeable about assessing pain, or are they expected to be knowledgeable?
Doesn't it?
That's right in the beginning.
Our physicians are encouraged to be knowledgeable about assessing pain. So that's what ours say. I can't speak for the rest of the department, though. I don't know if anybody else can comment on that.
Rebecca Dale?
Well, I can say that there is not official chronic pain training or acute pain training in medical school. So I think you'd have to look back at what the, sort of training expectations are to say if someone should or shouldn't be knowledgeable on it.
I mean, a pathologist probably doesn't need this, right, to be knowledgeable. So this is an example, someone who works in a laboratory.
Or is it just physicians and PAs seeing patients with pain conditions, right? Yeah. But isn't there someplace in the rule that it says that you should be familiar with the pain rules?
So that's in the continuing education piece.
Oh, okay. Okay.
Yeah, yeah.
I dropped the intent section for
That's
DOs.
osteo's entire?
Yeah, that's the entire thing for intent and
right.
scope. And I think the other boards and commissions are more aligned with that.
Yeah, I checked dental and podiatry are just that sentence as well.
So, I mean, and commissioners, if you want to do that, you certainly can. You can make it the same.
Well, I already said I like it short, and I think that in black in the middle is the most important part of it to make it a little longer.
So I think these are good directions for me, but that we will just go ahead and hold off on doing a lot of editing to this today, because I think a better idea would be to wait until we edit all the other sections that are in the opioid prescribing, and then we can bring this back like as the last thing we deal with before we go through the whole all of the other sections again, just to make sure they're tightened up and how you want them to be, before we request to move on to the next step in the rulemaking process. I think that's probably
Sounds
a better
good.
idea. Yeah.
Yeah.
That way you don't waste time here trying to wordsmith stuff that may not even be in here in 2-3 more workshops. So, okay. So
should we move on to the exclusions section, Amelia, or not?
that is up to you if you would like to do that. Let
What do you
me
think? I mean, you're yeah.
I think the exclusion section should wait because it is a controversial section. Because the ask for that section, we've talked about it previously, is that we exclude all rare diseases from the opioid prescribing rules. So, and we've talked about it before, and we've talked about how difficult that would be and complicated and things like that. So, I think we should wait on that particular section. My advice today is that since it's almost close, I mean, it's close to the time we would be ending anyway, that we not start another section today, and then we can focus on the exclusion section at the beginning of the next workshop.
Great idea. All right. Well, thanks everyone for your participation. Ms. Boyd, please discuss our next steps.
Okay, let me get together again here. I've had to close a lot of things. Okay. Okay, so the next steps for this rulemaking are additional workshops. The draft language that we've revised today will be available on this rules page, which is, you can click on the link there, and you can navigate there by clicking on that link. And it should be up there within the next couple of weeks. And then a notice will be sent out via our Gov Delivery distribution lists when the updated draft is available, as well as when the materials for the next workshop are available. If you have any questions about these dates, you can let me know now or send me an email. And then you can also leave additional comments on that rules page if you'd like. Those get pulled every time we have a workshop, or you can email them directly to medical.rules@wmc.wa.gov.
All right. Well, are there any questions that have not been addressed today? Please raise your hand, or if not, I don't see any. So I'll now close. Oh, there is one. Oh, thank you. Yes, thank you as well. I will now close the workshop, and it is 2:40 p.m. Thanks everyone for your participation. We really appreciate all of your input.
Thank
Thank you,
you.
everyone.
Thank you.